Okay, quick raw recording here because I just wanted to remind you all that for clinicians, physical therapists, mental health therapists, registered dietitians, occupational therapists, I do have a free monthly consultation group that's once a month, every third Friday of the month from 1 to 2:30 p.m. Eastern, and you're welcome to join by going to my website, clicking services for professionals, and finding the Community Mastermind tab. Also, Victoria Rodriguez and I are doing our second cohort. We're so excited for it. So this is a 6-week educational and consultation cohort. It's $550, 90-minute classes and consultation groups for 6 weeks starting April 7th. And this will be our last one for 2026. Our next one won't be until spring of 2027. So we hope you'll join us. And for people who are not clinicians, for just general public and those with chronic illnesses, I do still have my Welcome to the Waiting Room membership open. It's $17 a month. We have a support group every Friday, almost every Friday, for general support around navigating chronic illness and the different difficulties that come along with that. And every other Thursday in that same membership is a sex and chronic pain support group. And we also do a monthly educational workshop or webinar. That all comes packaged in that $17 a month. So we would love to have you. Okay, so just want to give a really big content warning here. We are talking about eating disorders in this episode, and there may be some language in here that is actually triggering for those who are very new to recovery or not even in recovery yet. So I do highly recommend skipping this episode if that's you. And if you do decide to listen to it and it brings anything up for you, I do hope that you have proper support with an eating disorder therapist and or dietitian to help you navigate what comes up for you in this episode. But I did think, though, that this was a very important episode to have because eating is fundamental to life and it can become disordered really quickly. And it can be really confusing, too, with all of the misinformation that's online and all of our different health conditions that require different diets, and sometimes those diets are accurate, sometimes they're not. And so this is an episode in trying to help you learn how to eat if eating is a struggle for you. Again, with that said, please take care of yourself and make sure that you have proper supports in place if you do feel like this episode could trigger some negative reactions for you. The Chronic Illness Therapist podcast is meant to be a place where people with chronic illnesses can come to feel heard, seen, and safe while listening to mental health therapists and other medical professionals talk about the realities of treating difficult conditions. This might be a new concept for you, one in which you never have to worry about someone inferring that it's all in your head. We dive deep into the human side of treating complex medical conditions and help you find professionals that leave you feeling hopeful for the future. I hope you love what you learned here, and please consider leaving a review or sharing this podcast with someone you love. This podcast is meant for educational purposes only. For specific questions related to your unique circumstances, please contact a licensed medical professional in your state of residence.
My name is Tiffany Pecoraro, and I am a registered dietitian. I have a telehealth private practice called Freedom with Nutrition, and I specialize in working with clients who have eating disorders and co-occurring chronic illness and complex medical conditions. And I love what I do. It's an honor to do it, and I plan to do it for a really long time.
I love that. What are some of the most common conditions that you see as of recent? And we can talk both on the mental health side and the physical condition side.
Yeah. So most clinicians are familiar with eating disorders and comorbid POTS. Oftentimes, as someone has more and more years of having an eating disorder that's pretty chronic, POTS is something that can pop up, and most people are familiar with that. Hypermobile EDS is a more recently kind of acknowledged one. Most clinicians are aware of that. Various different GI conditions, IBS more commonly, but like IBD, so Crohn's, colitis. I think a lot of clinicians like are more recently hearing about like MCAS and eating disorders. It is pretty like controversial though, like in the field of eating disorders, which we can get into like a little bit more in terms of like why that is. Autoimmune conditions are pretty commonly co-occurring, but I wouldn't say that like a lot of clinicians are necessarily like aware of that.
Yeah, thank you. I would love to really go right into what makes MCAS so controversial.
Yeah. So I think most like clients and clinicians who are familiar with MCAS like know that like just because someone has MCAS, it doesn't mean that they're necessarily going to need to go on a low histamine diet or like benefit from elimination diets or benefit from like food restriction or like limiting variety. But I think in the eating disorder world, that's like one of the concerns. So like, I mean, first for that to be controversial, someone would have to believe that like MCAS exists. So it's like usually either like it doesn't exist, like it's kind of like this like fake diagnosis, or if someone does have MCAS and the eating disorder, like what are the implications of that dietary wise, and just concerns around that like perpetuating like restriction or like limiting variety and like that kind of impeding someone's like recovery from an eating disorder standpoint.
Yeah, absolutely. Where do you stand on the belief aspect of MCAS? How do you work with MCAS and define it even for like, because especially a lot of people don't have that full MCAS diagnosis if they don't have the high trip levels, but they maybe have all of the other symptoms. Yeah. Can you go into like some of those nuances?
Yeah. So in terms of, I mean, I for sure like believe that it exists. So like that first and foremost. As I'm a dietitian, I can't diagnose anyone with MCAS. If I could diagnose, or like in terms of like alignment, in terms of like philosophy, I align more in terms of like consensus to criteria, where I do think that it's pretty uncommon for someone to get that gold standard lab proof that they have MCAS. So it just makes the most sense. So the client diagnosed based off of the symptoms and like the response to treatment, and just integrate that into the picture of like what might most benefit someone in terms of for my job, like dietary strategies and just like nutrition related practices to move forward in terms of eating disorder recovery, also kind of considering the MCAS component.
Yeah. Is it fair to say that one of your main goals is going to get people eating maybe not necessarily a certain amount of calories, but like really eating like good full meals? And you can define good as well. But yeah, can you tell me what your main goal is with clients? Like we want them fed and nutrition inside of their body. What does that look like for you, for someone who really wants specifics?
Yeah. So I think that adequate eating in terms of what I see with clients is for I mean, just really for anyone too, is like on a spectrum, and like spectrum with like the goal being like, I want to support them with like adequately nourishing their bodies. And part of that like is calories. Like I would say like it's like foundationally calories, even more so than like macronutrients, like if someone's getting enough fiber, vitamins and minerals, like we just like baseline enough calories to be able to function optimally. So it really depends on the client, but I think, and this kind of gets into like controversial territory too, like my mindset is like, I mean, this is a little bit too black and white to like put it this way, but like for the most part, by whatever means necessary, like even if it's for a certain period of time, maybe like utilizing like a behavior that might be like thought of as like more like disordered, if it's going to like move someone forward along that spectrum, then there's like utility to that, and like it's like practical. So for example, yeah. So for example, like food blogging, or like I mean honestly like even like calorie counting. So like that's like a big like no for the most part in the field, but a variety of different types of people and like a variety of different types of brains like experience eating disorders. And like particularly with my clients who are maybe neurodivergent, various different types of neurodivergence, there might just like be this, I shouldn't say like need, but just like there's just something tangible about like numbers, and it's just like easier in terms of like accountability, like to themselves and like maybe it's like to their providers to just like have a specific like number that like maybe it's not like, okay, like you have to stay within the spectrum, but it's like, okay, like at minimum, let's cross the threshold of this number. I've seen that to be like effective with clients when like other methods haven't been. So that would be an example. Another one, a little bit less controversial, but still controversial, like can be like food blogging. So a lot of people kind of experience like food blogging as like part of their eating disorder. So they might like download like MyFitnessPal or like various other like tracking apps and like log food from like a dieting, like calorie restriction standpoint. But like we can also use that like for good, where like maybe in that case, like it's not just calories, like it's just trying to hit like specific like macronutrient goals, like not in like a restrictive way, but in like a let's kind of know what our goal is and like kind of be like assessing how close we are to that like throughout the day type of a way.
Yeah, absolutely. I'll give an example of my own life. This was, gosh, years ago. And I downloaded, it was MyFitnessPal. And the whole reason what my goal was in tracking was to try to get myself eating more fruit and vegetables throughout the day. And as I was doing that, I realized that the more, I guess, quote unquote, healthy foods that I was eating, the less calories I was eating, which is where that trigger can come in, right? But it made me
100%.
like, I'm eating this huge ass salad and I feel really, really full and then I don't want to eat again. And so for me, it was eye-opening to be like, I needed more calories. Again, yeah. You know, even what I just said, like the salad made me full, could definitely like feed into an anorexic mindset. But that's where the holistic treatment comes in of like, yeah, we're talking about this and we want to how do you know you're getting the nutrients that your body needs you to get? Sometimes tracking is going to be the only way to do that. How do we make sure and deal with the triggers and the triggers that pop up? Like, yeah, you saw that there was 500 calories on this lunch today. Is that pushing you into eating less now because you're like, that was too much for a meal? Or is it going to help you reach more because you know you need more by the end of the day?
1,000%. Yeah. And I also like want to like, I guess, like clarify that it's not like that is like what I start with clients. Like every client is like individual. And I think that the goal is always to have the least restrictive of a diet and like the least amount of tracking as we can kind of get away with while still making progress. But like what you're describing, like I think that's like a common like experience like for individuals where like the intentions are like really like nourishing yourself and like it's also like really like hard sometimes to like kind of shift behaviors in that way, but then it can like result in just like under eating like from like a calorie standpoint, which can be helpful to see with like tracking.
Yeah, there's the overlap of these kind of diets that people will find online and the chronic illness. And so then you might start tracking in order to follow this diet. And what I've realized with some is that when they start to track their, like I said, with my own thing, they're eating less calories, and then that can mimic dizziness. It can mimic POTS. I'm sure you can speak more to that. Yeah. Now maybe we can talk a little bit about that, like when you're not eating enough calories, what that can start to mimic, especially when you do have a condition like POTS. It can feel almost gaslighty to be like, this is because you're not eating enough calories. And then you're like, but I have this condition. And it's like, yes. So this is just exacerbating that.
Yeah. It's really tricky because opposite things can happen, which makes it like really confusing, where like if you have like POTS, like you can feel like terrible like after eating, and you might be like eating a prescribed meal and like you legitimately feel worse. And like what human would want to continue to do something like consistently that makes them feel like worse afterwards? But I think in response to that, which like it makes sense, like maybe there's like patterns of like restriction or like under eating or like eating as minimally as possible to kind of function throughout the day, like earlier on in the day, just because it's so distracting to maybe someone's like concentration at school or like concentration like within like their workplace. And like maybe they're saving up their calories for later on in the day because that's the time that they can kind of get all their nutrition in and like they can sleep afterwards. And like it's not like a conscious awareness of like how uncomfortable it is if you're sleeping. So I think with patterns like that is in response to those physical symptoms, like that feel they're exacerbated by nutrition, but then like that pattern itself tends to worsen like symptoms where like it's kind of progressively more and more whatever symptoms they experienced initially.
Yeah. Yeah, I'm glad we're getting into this territory. This is kind of exactly the premise of this particular episode is it doesn't always feel good to eat. And, I think there's such a history of people telling us what is right or wrong for our body and not having the autonomy there. And so this treatment to nourish yourself can feel so prescribed and stripping your autonomy again. And so I'm wondering, how do we what do you see as kind of the thing that happens for people when they finally, it does actually become an autonomous choice to eat this kind of prescribed way again? What are some of the shifts that you help them with getting there? And anything else that comes to mind around that?
Yeah. So I think when someone has like experienced that, like it's like really hard to take the leap of faith of like, like trusting like any type of like provider, but B, like I think that there is like a loneliness that comes from that because like oftentimes like someone has experienced like maybe working with providers or like maybe they found something like online or like some type of like book that they read or like article that they read that is kind of like promising like, okay, like you've experienced this, like if you take these steps, like you'll feel better. They've trusted that, like modified their life to follow that. And then like symptoms just like didn't work out. So like there's kind of like this like unfortunate, like kind of like loneliness of like no one knows like how my body reacts to things. Like, so it's difficult to like trust and kind of having to be like your own doctor. So I think like at the point that someone is like coming to work with me, like they're already kind of like taking like that leap of faith and there's some level of like openness to like, okay, like I'm gonna like trust again, which is like a huge responsibility that like I want to like be so respectful and like careful of, because oftentimes like as we kind of shift eating patterns, like reactions like will happen. Like it's almost impossible to not have any type of like negative like symptoms that arise like when we're shifting patterns. I mean, even from like a hormonal like nervous system standpoint, like change is stressful and stress can produce like more cortisol, like that itself can like trigger some reactions. Kind of zooming out as like an aside, like even if someone doesn't have a chronic illness or co-occurring medical condition, like even if someone's just like navigating like solely eating disorder recovery, there's this common like kind of like disclaimer that like dietitians will give clients when we kind of give them the initial meal plan, where it's really like normal to have like kind of worsening like constipation, like reflux, stomach pain, like extreme fullness, like in the initial stages of changing your eating patterns. And usually that lasts around like 2 weeks. So even without the co-occurring chronic illness, like there's kind of like this 2-week period. But someone who does have maybe like a co-occurring condition that makes this like more complicated, like there's like that initial like 2-week period where like, okay, like this is like pretty typical, like most people like experience this. And after that point, like it's like we kind of almost like have to like trigger like whatever is going to happen, like to know how to kind of like address that and move forward. So maybe it's like lingering like constipation, like maybe someone's using like Miralax, like magnesium, just like everything, getting adequate amount of fiber, adequate amount of water, and they're just not having bowel movements, and kind of a little bit of like trial and error of like maybe there is like a food component, like maybe someone's like very, very sensitive to like dairy and like they need calcium, but we have to modify that like a bit. Like maybe like we're removing dairy. Maybe someone's like very sensitive to gluten and we're not like leading with that, but we're modifying things and kind of playing with things like with the goal of like, we have to make this like sustainable and like tenable, like so that we can like move forward with adequate nourishment.
Yeah, I'm hearing, I think one of the most important pieces of there is like the time frame. So there's this 2-week period where the change is going to give you some symptoms that, you should expect. And I think that's like one of the biggest parts of trauma-informed care for me. We haven't defined that yet in this episode, but trauma-informed care is having this responsiveness to the reactions and the resistance that clients might have to change, understanding that that resistance is very normal given what they've been through. And so that's what I'm hearing as the through here is like, it's all to be expected. And that's a part of our job as providers, whether you're a dietitian or a therapist or a physical therapist or even a medical doctor. It is our job to be responsive to the fact you might not be doing the trauma treatment, but you have to be responsive to the fact that there is a trauma response here that makes sense. It's not pathological. And so maybe that 2-week period is also a part of what helps somebody buy into this is like, okay, I can withstand almost anything for 2 weeks. Like, you know, our chronic illness lasts way longer than that. So we manage those symptoms every day. So what is that a solid rule, the 2 weeks? What happens if somebody's like, I have been doing exactly what you've asked for 2 weeks and I'm still having constipation or I'm still, how do we navigate that next?
Yeah. So, I mean, I think it's tempting for me to kind of view everything as a nail that I can kind of hit with the nutrition hammer and solve it. And sometimes that is something that's like modifiable, like the examples that I gave. And like sometimes we are tweaking those things and nothing changes, or it does eventually like resolve on its own. And we don't have to exclude something or we can reincorporate something. But I think like if something is just like I've exhausted kind of all the things that I can think of to support a client. And like, even before that, this is helpful. It's just really, really, really helpful to like the renourishment process. If someone has like a provider that is obviously if they're like aware and like kind of like specialized in their condition, but even if they're not, like is willing to listen and believe a client to provide kind of supportive medications to just make it something that like someone can endure, because it's just like it's uncomfortable to like go from a place of like not nourishing adequately to adequately nourishing.
Yeah, I like that phrase, renourishment process. I'm sure it sounds like one that you probably say a lot, but that's a new one for me. Another question that comes up is, how do we determine scary sensations from the sensations that are this normal part of like the body responding to change?
Yeah. I think that sometimes is like clear cut, but I think almost like everything is a Venn diagram overlap, where I think with the field of eating disorders, disproportionately symptoms that may also be stemming from chronic illness are kind of put into like this eating disorder box, whereas like, okay, like someone's intention for doing this like must be like the eating disorder. It must be like trying to like reduce calories or lose weight or some type of eating disorder intention. But I think that it's so, I mean, we're nuanced human beings. Everyone is like nuanced. And I think that there's this overlap of, okay, this is maybe also serving the eating disorder, or maybe like some part of it kind of feels soothing from the eating disorder standpoint. But there's also this like very real intention of like, okay, I just don't want to feel bloated, so I'm not having X, Y, and Z at this meal. But at the same time, it kind of serves the eating disorder's purpose of reducing the caloric content or carb content or what have you of that meal.
Yeah. And I also maybe should have brought this in earlier too, but are we more so talking more on the anorexic end of eating disorders? And I'm wondering if you do work with binge eating disorder and are there others that we are not touching on?
Yeah. So, I mean, I see like co-occurring chronic illness and medical conditions with just like every diagnosis. So like there's like RFID, like the weight and restrictive food intake disorder, anorexia, like bulimia, binge eating disorder. There's also OSTED, where it's otherwise specified feeding or eating disorder. It's kind of like a catch-all. So like someone might meet like most criteria for anorexia, but like some, like they're not like engaging in the frequency, or it's not like just kind of shy of like a certain criteria. So I think it just really spans like the whole gamut of all different eating disorder diagnoses.
Makes sense. Yeah, because we're talking about, I think we're giving great examples for anorexia. One example that comes to mind for binge eating disorder is something like GERD, or just chronic acid reflux, and then eating kind of calms that down. So they're eating maybe a lot more frequently than what really their body wants to, but that one particular symptom is calmed so much by the food. Are there other is there other
Yeah.
that you can give?
Yeah. I also don't want to like pathologize someone's response to a symptom and kind of treating it with food, because like that can be health giving and helpful. But I think that there are situations with binge eating disorder, for example, where maybe someone has like POTS and like they experience like significant symptoms, like kind of relative to like fluctuating like blood sugars. And like maybe like if their blood sugar is like dipping like low, like things get a lot worse. So like that sensation of blood sugar dipping or like a specific like feeling in their body might be very triggering. And it's not, I mean, it's not necessarily disordered. Like it makes a lot of sense, but maybe because they're kind of trying to be really proactive, there's kind of this pattern of treating every feeling like that with eating, and that can kind of become sometimes disorder, like in like a more like kind of binging, like or overeating, or even just grazing throughout the day in a way that is maybe interfering to some extent.
Yeah, that's what I'm thinking too, is like, and I agree. I mean, yeah, we are pathologized a lot for the way that we cope, and in a wide range of conditions from mental health to physical health. And it is important that we don't pathologize that. And then how do we bring that into the context of what their personal goals are, or what nutrition is doing for or against their body in other ways? And so I'm assuming that those are all a part of your conversations as you're trying to figure out a treatment plan with clients.
Yeah, yeah. And I think that like, I mean, I work with like adults, which I think is like an advantage, like when it comes to this for sure. I think it's a little bit tricky if it's adolescents, but like clients are coming to me wanting for something to be different, like they're wanting to change. So I think that there's like an understanding that this is going to be uncomfortable. So I think that oftentimes with that example, like with like the POTS symptoms and like binge eating disorder, like it can also be like difficult for clients to like receive the feedback from me that like something may not be disordered, because it may feel really out of control and like disordered for them. So I think it goes both ways, where it can be super validating and okay, we can kind of understand what's going on and kind of create a plan to navigate this, but it can also feel really hard to get the feedback of like, okay, this isn't sounding disorder, like this makes sense as a normal response.
Yeah. What is the hope and intention there when you're going down that conversation with a client? Like, what is the, as you're trying to explain that, what is the hope and intention on the other end of that?
Like in terms of like the not pathologizing, or like kind of like
letting
normalize.
them know, like, no, this is not actually disordered. This is, and then they're not loving that feedback. What is the hope at the other end of that conversation?
Yeah.
What is the piece that maybe you want them to eventually come away from with?
Yeah. That's a really good question. It's first kind of normalizing that, because I'm kind of looking ahead, and if we're viewing that as a problem and treating that, then there's kind of the risk of more disordered eating patterns that could occur, or like someone like not getting an adequate amount of nourishment, or experiencing a lot of confusion with, okay, what are the cues that I'm supposed to respond to? So I think it can be hard for the client, but it's important for me to give that feedback, because then I can ask the client more of what are other things that are making that feel disordered. So it could be the fact that they feel they have no control around like when they need to eat, or when they can kind of take a breather and like they don't have to think about it. Just like this constant kind of like hypervigilance that might feel out of control, that just like their blood sugar or this experience in their body of low blood sugar just runs their life. It can be, I mean, it can be being at school or being in work and just not kind of being at the mercy of whatever is happening in your body in terms of what you perceive your blood sugar to be or what your blood sugar is, and just being able to perform, or wanting to be able to perform, but not being able to rely on just like
Your body's cue.
I'm losing my train of thought in terms of like words, but like not being able to, what am I trying to say, like just not having like that confidence of like, okay, like my body and my brain's gonna like do its thing when I depend on it.
Definitely. That makes perfect sense. I think, essentially saying you're teaching them intuition, and intuition doesn't always look very easy. It often can look messy. And so it is intuitive that your body is giving you these symptoms and that matches this picture of disordered eating, but we're not going to pathologize it in an effort to allow you to trust your body again so that you can then have this good foundation for which you can start to change in a way that's in alignment with values and goal.
Yeah, yeah. And that's a good way to put it. And like I like that you use the word intuition too, because we talk a lot about intuitive eating, like in the nutrition space and eating disorder recovery spaces. And I think that that's not always practical. I think that we can like kind of build skills around intuitive eating and like kind of also just like knowing like how our bodies feel and like how to take care of our bodies and like how to respond to those cues. But I think that there's also like feelings that aren't reflective of what's actually going on. Like there's intuitive like kind of signals that we think that we're getting that's not always like reflective of like what our bodies need. For example, when I'm working with clients with like anorexia, like they might like literally like constantly feel full. Like someone might consume like a very small amount and feel like legitimately full for like 5 hours afterwards. But that's like an intuitive like sense that they're getting. Like that is like an intuitive kind of like feedback signal that they're getting from their bodies, but it's not reflective of their actual nutrition need.
Yeah. I love that nuance there. Honestly, I'm even thinking about like my own experience that I kind of relate this to ADHD more than anything, but more of like I can go hours not eating and not realizing that my body needs food and that I am hungry, but I don't have any awareness of it. And then there have been other times where I'm eating all day and I'm really not hungry, but I'm kind of like grazing.
Yeah.
So yeah, I agree. I think intuitive eating has this like chokehold on, and it can confuse people because our body is not, honestly, the same thing happens in the conversation around childbirth. I've given birth twice now, and everybody loves to talk about it as the most natural thing in the world, and your body just knows how to do it. And it's like, actually, it really doesn't. And that's why a lot of us don't have a great experience or worse in this particular event. And we just need so much more direction and mentorship. And, we don't pass down wisdom like we used to either in childbirth, as well as I'm imagining in food, I think, as well.
Yeah. Yeah. Like just like reassurance that what you're experiencing is normal. Just a roadmap for like, okay, these are typical kind of ranges of experiences.
Exactly. Yeah. And then, typical ranges of experience. And then when this is outside the range of that experience, you need help, you need intervention. And that's a good thing. Like it's a good thing to get help and support when your body is not. Yeah, I think the whole like natural approach to it all makes it sound like, well, anything your body is telling you is just natural and you can get through it on your own. And that's the danger. Again, I saw so much in my own childbirth journeys as well as in the intuitive eating world.
100%. Yeah. I think another thing that like it's not necessarily like the chronic illness piece, but like another thing that I see a lot kind of impacting those intuitive cues is clients who are active in like sports or like maybe like as like a hobby, they're long distance runners or they engage in like, maybe it's not from like eating disorder standpoint, like maybe it's not even compulsive exercise and maybe someone's even fueling adequately or trying to, maybe the intention is there to fuel adequately. But I think like certain physical activity forms can really suppress appetite. That can mess with intuitive eating cues. Like if someone's running long distances, that actually suppresses appetite. So they might need to kind of like push past their actual intuitive cues to adequately nourish. Or if someone is grieving or like stress, like obviously like chemotherapy would be like a common one. There's just like so many things that like we like kind of recognize like impact intuitive cues. But I think that like we often think of that as like separate from like these other things that like are a little bit like more under the radar that can impact our sense of like intuitive cues as well.
Yeah. That makes me wonder, like, and again, just always bringing the nuance in and making sure folks are not taking any kind of rigidness away from this. But I would imagine like, right, if I'm grieving the loss of a loved one and I don't feel like eating, like that's okay. But if you're dealing with depression and this is a daily feeling that you're feeling, then we've got to work on that. Would you say that differently, or would you, how would you approach that kind of?
I think like my answer might be like specific to the fact that I work with clients with eating disorders, but I do work with clients who are like experiencing those things. I think with Whether you have an eating disorder with a chronic condition or you just have an eating disorder, there are studies that kind of reflect that if someone who is genetically predisposed to an eating disorder, which like you wouldn't necessarily like know, like going about life, because like you wouldn't know like until like you have an eating disorder, goes below their specific body's kind of safe set point, then it can epigenetically kind of express some of the genes that could like then like turn on like the eating disorder part of their brain and like perpetuate that. So I think that I'm like a little bit more, I guess, like stringent with clients, like in like it's so valid, like if you're like going through like grief or like some type of loss or a major life stress, for that to just completely zap your appetite and for it to like even feel really cruel or just like unfair to be expected to continue on with nutrition, because it may not feel like woman probably doesn't care in that situation what's happening nutrition wise, like they have like bigger fish to fry.
Yeah.
But I think it's just like so risky to like undereat and to like lose weight, because that can make the eating disorder just so much more severe, or it can like even cause someone who like didn't know that they were predisposed to an eating disorder to kind of like develop an eating disorder like afresh. That like I'm maybe like a little bit like more firm when it comes to that and supporting clients.
Yeah, my brain goes back to our conversation around the autonomy piece, and I wonder how can only see how tricky that would be to kind of lean into autonomy here while you're also really at a high risk for relapse. And so even presenting that as options, right? Like we completely understand that your body has shut down its hunger cues. And here's, a reminder of how that nutrition helps you get through the grief or helps you get through the next moment tomorrow morning. Like, yeah, that's kind of what comes to mind so far.
Yeah. And I think with anorexia or even other conditions that can lead to eating, there's like often like alexithymia that kind of develops where it kind of does have an effective like numbing emotions quality to not be getting like adequate nutrition. So like I think it's like so much more like challenging even in those situations, because like doing like what you need to do nutrition wise can actually make it like more unpleasant, like and even like acknowledging that, because maybe it like feels much better to be able to like numb out like emotions, and it feels so distressing to be like experiencing those emotions and to have adequate nutrition on board to be able to feel, but still nourishing yourself for just the life that you kind of want to continue to live and maintain like several months down the line, where like the grief isn't as intense and acute as it may be like in the moment.
Yeah, that makes me think of executive functioning skills on top of all of this. And because even just the idea of you might not feel like eating, and then on top of that, if the executive functioning that is required to feed yourself, like plan the meal, cook the meal, put the meal on a plate, get it to your mouth, like all of that can feel so hard, each one of those steps. And so then on top of it, you're dealing with something really difficult. Yeah, it's a lot. And that's where I think, so far we're just talking about the individual, but that's where community comes in. And I think, a lot of cultures, even in our culture, I would say like, food is a big part, like potlucks to a funeral, or like where people bring food to the family. And I think that makes sense that we've developed that in most of our traditions, given that when you're feeling that way, you really don't want to cook for yourself. You don't want to think about any of that.
Yeah, 1,000%. And I think also like that's a time whatever like the source of calories is, the goal is just getting an adequate amount. So it could be just soul nutrition is just like a certain amount of like Ensure pluses like per day, or like Kate Farms, or like Soylent. And like that's okay. Like it doesn't have to be like solid food. It's just like whatever gets the job done, like realistically.
Yeah, that's really helpful too. I think, I'm imagining 10 different people could walk away from listening to this episode with, 10 different kind of takeaways. And so just reiterating that the main goal we want to get across here, and hopefully we did an okay job of this, is like letting go of rigid rules while also still having a regimented a way of nourishing your body. And that's tricky, because when you start to talk about eating 3 times a day minimum, that's pretty rigid if you want to put it that way. And also there's flexibility Something I often tell when I used to work with parents a lot in a mental health center, what I would tell them often is we want to provide our kids with consistency with flexibility. And I think that that's probably what applies here too, is we want to be consistent. And yeah, that can sound a bit rigid, with flexibility. This isn't meant to be robotic, or you fail if you not eat 3 meals today, or, you fail if you had a shake instead of, because I think that's the other piece. Like, people might hear, I know that people can rely sometimes so much on Kate Farms, and then it further exacerbates motility slowing. And so it's like, that's why, again, you work with somebody who is really well versed in all of it. And that's why these podcasts are just, when I say that they are a general education purpose and not medical treatment, that's not just a phrase I have to put for legality. It is just really true, because Kate Farms might be the right thing for me and the wrong thing for the next person. And it really just depends on your particular situation.
Yeah, 1,000%. And like, I mean, I'm a big fan of ChatGPT, but I think that's like one of the risks of ChatGPT too, where like it just like, it feels like chat is like understanding you and is like kind of giving you like this confident like prescription based off of like all the symptoms that you sent it, and with the little text box. But like, yeah, like I think that my main goal with clients is the goal with like the outcome of like getting closer to adequate nutrition. And like, that's like the consistency, where it's like the goal is like pretty like steadfast and consistent. And like, there's just like unlimited like flexibility and like all the creative ways that we can get there. And that's going to look different for each person depending on like what they're contending with and like managing.
Yeah, I think that's such a good point. Is there anything else that feels important that we either didn't cover, or just like another thing that you want to make sure people really leave with today?
I think that like GLP-1s, like I think like in the chronic illness world, it's like tricky because there's so much exciting research coming out around how GLP-1 microdoses can be really effective for certain conditions in terms of like managing the inflammation, and doses that aren't really affecting weight. And I think like at like the more typical doses, it can have like a profound impact on appetite. And like a lot of times like people say that it feels like possible to intuitively eat. And I would just like, not that this like applies to like everyone, like just put like a little bit of like a like asterisk, like maybe like a little bit of like a warning mark there, where like that's like a little bit like dangerous, because if you're taking a medication that significantly reduces your appetite, it's probably best to like work with someone that can at least give you some level of like direction in terms of what's the absolute minimum you don't want to go below, even if your appetite like matches like the lower amount.
Yeah, that's such a good point. Definitely important to add here, because you're right. Like, there are so many conditions that are getting this off-label use now, chronic illness conditions. And so it would be very appealing for somebody, even someone who doesn't care about weight and, things like that, but they might want to go on this for, to calm their mast cell activation syndrome or something like that. And yeah, such an important reminder for everybody. Are there dietitians, and would you consider yourself one of those dietitians that would work with somebody on a GLP-1 and keeping their nutrition up?
Yeah, I mean that it's just like a lot of things, like very controversial, like as an eating disorder dietitian to even say that. But like, I'm pretty agnostic towards the GLP-1s. It's just, I feel clients can like make that decision, and oftentimes like it makes sense, and it's some level of quality of life enhancing effect that they're receiving. So as long as we can have that on board, it's improving their quality of life, and we're still working on adequate nutrition, and that being the ultimate goal, and that being something that plausibly we can work towards, I don't really have like strong opinions like against it.
Thank you so much for everything you shared today. I think that this is going to be really helpful for a lot of people. And yeah, I know you are licensed in quite a few states, so I won't make you list them all here, but I think they're all on your website. Yeah.
Yeah, all on my website.
Perfect. And so, yeah, we'll link your website below and everything else. And thank you so much.
Thank you for having me.
Thanks for listening. If you learned something new today, consider writing it down in your phone notes or journal and make that new neural pathway light up. Better yet, I'd love to hear from you. Send me a DM on Instagram, email me, or leave a voice memo for us to play on the next show. The way you summarize your takeaways can be the perfect little soundbite that someone else might need. And lastly, leaving a review really helps others find this podcast, so please do if you found this episode helpful. And P.S., clicking subscribe ensures you'll be here for the next episode. See you then.